A large part of maternal mortality is due to mental health issues. It's impossible to feel taken care of if you have a 4-week-old newborn and you're going back to work tomorrow.
I want to start the conversation by asking you the pathway of becoming a certified nurse midwife.
I think there's a lot of confusion and misconceptions about where we fit within the nursing world. Kind of to start off the 4 different avenues to become an advanced practice nurse. So there's a nurse practitioner, which is the most well-known, and within nurse practitioners, there's different specialties. There's the nurse anesthetist, there's clinical nurse specialists, and then we are certified nurse midwives are the 4th kind of realm of APRN. So we are separate from nurse practitioners. The pathway to become a CNM is getting your bachelor's in nursing and then a master's in midwifery, so the BSN plus the MSN. There are some programs that are just the MSN alone, and then there are also programs where you can go straight through your BSN and your MSN. I personally did the BSN program as an undergraduate, worked as an RN for a couple of years, and then earned my MSN. If it's their second career or something like that, they'll go straight through BSN and MSN and come out as a midwife.
Could you tell us about the history of midwifery?
It's important to understand how we got to where midwifery is today in the US specifically. Many people know that midwives are, we're one of the oldest professions globally. Here in the US, we only have about 12% of births attended by midwives. And that's a big change from even a couple of centuries ago. To go into a little bit of how that happened, up until like the 1900s, almost all births were attended by midwives at the home in the States. And most of those midwives were trained via apprenticeship with older, experienced midwives in their communities. And many of these midwives were Black or Indigenous midwives who really played vital roles in their communities because they were often the only primary care provider within their community. In the early 1900s, the medical specialty of obstetrics, or people known as OBGYNs, started to really grow, and birth started to move into the hospital setting and become a lot more medicalized. There was a lot of push against midwives. Midwives were kind of seen as a threat to the growing physician workforce of OBGYNs that were mainly white men. So there was this big divide between midwives of color who had been doing their thing for, many, many, many years, and this new kind of wave of OBGYNs. Early 1900s, midwifery was essentially eliminated by a lot of laws and restrictions and just stigmatization around the idea of having a midwife and giving birth at home. It was seen as unsafe, uncleanly. It was very stigmatized. So fast forward to like the 60s to 70s, this new role of the certified nurse midwife was created, which was kind of seen as this new professional idea of a midwife. It melded the ideas of midwifery with a professional nursing background. And while this was good because it started to kind of reintroduce the idea of midwives in a more positive light, and midwives who could start working within hospital settings as well as birth centers and home births, it's important to note that the profession of the CNM was really founded by white women and still today is primarily white profession. So that's kind of like it's not new, it's been that way since the 60s, 70s, but we're starting to address now how there's a real lack of racial and ethnic diversity within CNMs. The idea of midwifery care is providing really compassionate and culturally congruent care within communities. In order to do that, we really need a midwifery workforce that matches the patients that we're caring for.
That's amazing that you went over the US history in midwifery, because I had no idea.
Yeah. And a lot of people still, I still have patients who I walk in and say, hi, I'm the midwife going to be taking care of you. And they still think midwives are deliver babies off in flowery fields and do witchy herbal medicine.
Do you have interest in inpatient specifically, or do you also want to expand to a community health setting?
I just recently graduated in May, so this is my first job and I'm working in a large teaching hospital. But I was really torn between the two, and I think a lot of CNMs are. It's a tricky situation because our healthcare system is not set up to easily facilitate jobs in birth centers and home births. A lot of times, if you're a home birth midwife, you may not have professional liability insurance. That's like a whole huge barrier. Working in birth centers, you may work very long, crazy hours. As a brand new CNM, I wanted the security of working in a place. I would have that liability insurance. I would have those OBGYNs to collaborate with when a high risk condition comes up that I can't manage. I have that person there to go to.
What is the process of delivering in patient's perspective? Do they pick where they want to give birth?
Yes, I think it really depends on where in the states you are. Some states do not have birth centers. Some states do not allow home birth. More rural areas tend to have, smaller hospitals, and people may not have as many options versus New York City, where I worked. You can decide between 12 different hospitals you want to deliver at. I think people more and more are having an idea of the different spaces they can deliver in, birth center, home birth versus hospital birth. And people are starting to ask more questions about what are midwives? Can I deliver with a midwife? Am I eligible to deliver with a midwife? Where would I deliver with a midwife?
When a patient gives birth at home, how does insurance get covered?
That's a great question. A lot of times it is not. A lot of times it is out of pocket. As a provider as well, when you're not getting reimbursement from insurance companies, that's a big hit to your income as well. And it's a really hard lifestyle. You're working, you're usually on call all the time for your patients if you're a home birth midwife.
I mean, we cannot ignore that aspect, the financial aspect, right?
Yeah. No, people, we have lives too as healthcare providers, and, we have bills to pay too. And at the end of the day, no matter how passionate you are about a job, if you can't make ends meet with that particular avenue, it's really challenging.
What barriers do you see in pregnant women delivering safely in the US?
I know many have probably heard of maternal mortality crisis here in the States. The United States has the worst maternal mortality rate of any wealthy industrialized nation. Rates in Black and Hispanic women are like 2 to 3 times higher. There's access to care issues for many, many people, particularly prior to and after pregnancy and the postpartum period. There's a lot of, general rises in chronic health conditions. There's a lack of opportunity to provide equitable care. And I think a lot of our, poor populations who can't access care until pregnancy have a lot of chronic health conditions that have been going unmanaged. Throw on top of that language barriers. Where I'm currently working in the clinic, we get every language under the sun. Like, I'm constantly on the interpreter on my phone, whether it's Portuguese, Spanish, Russian, Korean, just everything. It's challenging, to have back-to-back 15-minute visits with pregnant patients, and you're trying to manage all of their concerns within 15 minutes with a language line. What we're starting to address recently is healthcare providers' implicit biases about patients. We see that when you're on the floor, working with patients and providers, you see those implicit biases come out. And we're starting to notice that as an issue and address it through talking about it, trainings, education, things like that. Pregnancy and postpartum, health here in the States does not match how wealthy of a nation we are at all.
As you said, there is this gap in providers that we are not diverse, even though the patient population is very diverse. And even though I don't know midwifery that well, anything that we do, from food to how we live and our lifestyle, culture factors into it tremendously. Yeah. So I believe making our workforce diverse can also help tackle what you talked about, getting rid of that bias that we have.
Yeah, I think it's really similar, to draw like a similarity to the political world, how we're really starting to push to get more people who look like us in the White House and, in the House and the Senate, the people who are giving you information about your body and your health and, helping you access the care you need. we should be diverse and we should, mirror the patients that we're taking care of.
And, having that role model too, when I was in grad school, I had a Filipino nursing professor who mentioned that when she saw another Filipino nursing professor, she realized then that she could become one too. I think making that the workforce more diverse can show the next generation nurses that you can do this too.
Totally.
So for sure.
Yeah,
Yes.
I think that's so important.
What do you think is the general sentiment about financial investment among nurses in the US?
This is just like my experience and the nurses that I know. I think most people who are driven into this field are typically not at least solely fixated on money or financial gain. I think many of us are driven into this field for a genuine desire to care for people and also to have a steady and reliable job. I do think that's a draw into the nursing field. And so we typically have good job security and typically good benefits as well, retirement, things like that, at least if you're working in a hospital setting. In my personal experience, I don't know a lot of nurses who are really driven for financial gain. But with that being said, I did have this thought during the COVID era. I think we've seen a big rise in travel nursing. It's opened up this new avenue for bedside nurses, which is typically like seen as kind of a humble, steady kind of career, to like travel to a different city and make like this crazy income, 4,000 or 5,000 a week. For many people, it's not realistic for their lifestyle, but it's a pretty like lucrative avenue to go. In both nursing and midwifery school, we never really learned a lot about business or finance, learning how to open a practice, learning billing and coding, and as a master's student, how to work with insurance companies that are really important when you hit the ground running as a provider, especially. I think those things are not worked into our curriculum, and that's an area that could maybe expand in the future.
So I was talking to a nurse manager, and he was talking about the same thing that you just mentioned, that nurses, we don't get financial education. I didn't go to school here in the US. I moved here for college. So do you get that financial education in like elementary school, middle school, high school?
No, like I didn't even know how to do my taxes coming out of college. Like
TurboTax.
Accountant. Luckily, my parents are accountants, so I have like them.
Amazing.
All back. But no, I feel like that's a big gap, even down to like a retirement fund. And like, I can't tell you how much I've called my older sister, who's like 3 years ahead of me in all of these life stages of like, what the heck do I do for like, my retirement, for whatever.
We just need to hit the ground and just learn it ourselves. And it can be very overwhelming. What kind of investment do you make for yourself?
I'm still a little bit broke after school, to be quite honest. I went from high school straight into nursing school for 4 years. I worked for 1 year as a nurse and then went straight into my master's program, which I paid for all out of pocket myself. Higher education in this country is exorbitantly expensive, as many people know, and it is hard to have any kind of savings or discretionary income as a student. I'm still kind of like I'm now working full-time as a midwife and, starting to pay back loans, which is, a big thing, and starting to try to think about investing my money wisely. Retirement funds, like we talked about, is a huge thing. As a healthcare provider, you usually have a 403b. It's like setting that percentage, however much to come out of your paycheck, is really important.
Right, for savings.
And then, having like a personal savings account, applying to scholarships is a huge thing that was really helpful to me throughout undergrad and grad school. I just applied to all the scholarships, put yourself out there for whatever scholarship opportunities.
For those Korean nurses who don't know how much US college and grad schools are, could you give us a sense or a ballpark of how much it costs in a year?
Undergrad, I believe it's anywhere from 60 to 80K per year.
Just school alone?
Yeah, that's just like tuition. There's financial aid here. So depending on household income, things like that, you may get some financial aid to help with that. For grad school, and I did a 2.5-year program, per semester was around 12,000. So again, I leaned heavily on scholarships and did take out some student loans as well. And I was working part-time, which a lot of people do in grad school. If you have a steady nursing job, a lot of times the hospital or health system you're working for as a nurse will help pay for your grad school.
When I was getting my master's, I think more than half of my class were working as full-time nurses. So the hospital can pay part of their tuition.
Yeah.
I had many nurses who are commuting from New York to Philadelphia. In Korea, in a semester, it's about 3 to 5K. Still, that is a financial burden to many people, but compared to what we have here, no, we have privilege per se.
Yeah.
I have extensive experience at New York Presbyterian and NYU. From your experience, who do you think makes a good L&D nurse?
So first of all, I think there's a big misconception out there in the nursing world that labor and delivery nurses just cuddle with babies all day. I just want to start with it is not like that. As labor and delivery nurses, we spend 1% of time with the baby. Almost all of our work is triaging pregnant patients who are coming in with various, not just labor complaints. They may have bleeding, they may have fever, severe abdominal pain. We call it our own mini hospital because we have our own emergency room, which is our triage. Any pregnant patient who has any complaint typically comes into our triage. So triage is one area where we work as L&D nurses, and there you have to have the same mindset as an ED. You have to be quick on your feet. You have to know what labs to order, what imaging to order. So I think being quick on your feet. Once patients move into a labor room, so when they're in labor, typically the providers, whether it's a doctor or midwife, will be checking in on the patient periodically, but there's continuous care that's needed for a laboring patient, and that as an L&D nurse, you are the one there. So that's why our patient to nurse ratio is usually 2 to 1. It's kind of like the ICU setting, right? Where your patient needs continuous care. You have to be really compassionate and caring. You're caring for people who are in pain. It's a different kind of pain than surgical pain, although we do care for patients after C-section. So we do perioperative care as well. You have to be sometimes creative in how you help patients manage their pain. And critical thinking, with any nursing profession. Postpartum, our patients, once they deliver, we're there throughout the delivery and the birth. And then our 2 patients become 4 patients, right? We're usually, as an L&D nurse, taking care of mom and baby for the first couple hours after birth, keeping a close eye out for any bleeding. We're checking baby's vital signs, mom's vital signs, helping facilitate breastfeeding if that's what the patient is wanting to do. Then once mom and baby are stable, we transfer them over to the postpartum or mother baby unit. We also work, as I said, in the OR. So we are trained to scrub. We are trained to circulate in the operating room during C-sections. If our patient's going back for an urgent C-section, we have to switch caps very quickly, become a perioperative nurse, get in the OR. We're counting sponges. We're, counting instruments with the surgical tech. We're ordering blood if the patient's having a hemorrhage. It's a lot that can be going on. Baby's usually there in the recovery room with them, so we're facilitating bonding.
I realize L&D nurses, they have to be everything. They have to be ER nurse, they have to be women's health nurse, they have to be postpartum OR nurse.
I think this is almost most important, but you can't forget you are being a part of often the best or worst days of their lives. These are big moments for your patients. They're often very emotional, either happy emotion or sad emotion. We do care for people who have pregnancy loss, whether it be miscarriages or abortion. I think it takes a certain type of nurse to be able to compartmentalize all that, care for patients as they're going through those really big highs and lows.
Tell us what the labor setting is like in the US.
Prior to COVID, I don't even remember. I think you could have a handful of people in your labor room. People would have 5 family members in there. I think most places at some point during the pandemic, the laboring person plus 1 person could come with them. And now most places have 2 visitors that can come with the laboring person. You come in labor or with some other complaint, you're admitted into triage. And then if you are admitted for labor, you would move to a labor and delivery room. And typically those are almost always private rooms. You will be monitored, your baby will be monitored. After you deliver, you'll usually stay in that labor and delivery room for a couple of hours, and then you'll be transferred to a different unit, the postpartum unit, where you'll stay anywhere from 1 to 3 nights, depending on if you had a vaginal birth or a C-section. You'll get care for both you and the baby during that time. What is it like in Korea?
I believe it's usually the laboring person and a partner. It's more like an OR setting though than a huge room that we have here.
Interesting.
Yeah. Length of stay also varies. In Korea, you stay for longer than 1 to 2 days. I don't know whether it changed, but they bed rest you.
That's a huge thing that I want to learn more about, but I feel like in a lot of the Asian cultures, the period of rest in postpartum looks very different. That's a big difference from the experience here. A lot of parents are kind of expected to do everything on their own. There's this idea that 6 weeks after birth, everything goes back to normal, which is totally not realistic.
So the maternity leave in the States is very short.
Yeah, that's a huge, huge thing.
What is it right now?
I have patients who go back as soon as 4 weeks. 12 weeks is like the standard. Maternal leave is a huge part of even the maternal mortality crisis. I think we were talking in just maternal outcomes. A large part of maternal mortality is due to mental health issues, substance use. It's impossible to feel taken care of, supported if you have a 4-week-old newborn and you're going back to work tomorrow and you're trying to figure out how to pump and feed the baby and who's going to take care of the baby. Childcare is expensive. That's an area we need a lot more support. I think the postpartum period during pregnancy, we see people every couple weeks for 9 months, they give birth and we're like, all right, go do your thing. We'll see you in 6 weeks for your 6-week checkup and then you're good. And there is so much more support that people need postpartum.
How can the audience connect with you online?
I am on LinkedIn, Juli Choi, Juli, and my last name is Choi, Choi. I'm also on Instagram. You can find me Juliana Choi. I'd love to connect with anyone out there who wants to learn more about midwifery or birth or nursing, L&D nursing. Please feel free to reach out.